error would be in the surgeon. So the surgeon will have to learn how to work with the robot and then do it. And so overall, if you look at well-defined operations, the error rate goes down about 90% when you use the robot compared to when you do not use the robot.
Suppose a surgeon you have to sneeze or cough or do those kind of, and you have very mild tremors which comes out. So robot will see that and will not take it to the body. So they will stop that. It's a that's a simple example of saying how safe it is. So there will be many such safety pointers.
So have you trained your doctors for the surgery?
Yes, we have started the training and it will go on for some more time. And actually, Vattikuti Foundation and Institute of Europe Dr. Menon is the trainer for us, will be guide for us and will help us, the whole institute.
Training will be done at specialized places. Depending on urology means they will be trained for that, and there will be visiting surgeons who will come here and train them. So it's a long process, and surgeons will come to speed very quickly because they are already surgeons. They are only getting to use the new machine. Otherwise, they are already experts in surgeons. So this training will happen over the next few months in different faculties: urology, gynecology, ENT, and so on.
These patients with renal cell carcinoma and extensive thrombus in the inferior vena cava, which extend almost supradiaphragmatic. We were called in very often to open the chest and put a tape around the inferior vena cava just below the right atrium. Now, if you're doing a robotic surgery, would you consider also approaching it through a robo, or would you like open incision? And I know it's a...
At this point, I would still prefer an open incision because many times these patients need to be exsanguinated and put on bypass. If you can get a thrombus just below the right atrium, if you can get a loop around that, there may be no reason to do that. But what you have to do is to be able to rotate the liver. So, and I am sure that working with the liver transplant surgeon, it would be fairly easy to rotate the liver. As a urologist, I can rotate the liver part, but then I chicken out there. We can't get our liver transplant surgeons to come in and rotate the liver because they are not used to using the robot. But this is the future, and I think that can be done there. But if the tumor extends into the atrium and into the ventricle, you will need to do it.
Has it ever been used in Budd-Chiari syndromes? The robot?
For doing
well, you have
doing a portal obstruction shunt?
Yeah, but normally in the Budd-Chiari syndrome, we put a conduit just into the IVC and into the right atrium if you can, because it's a posterior hepatic blockage of the IVC. I don't know if it's been done at all or not.
I don't think...
I haven't read of it.
Yeah, I'm not aware of that.
Budd-Chiari syndrome is basically thrombosis of the hepatic vein.
Yes.
And maybe with the tumor extending up to the right atrium or to the inferior vena cava, he meant to say. In that situation, what should be done? That's why he meant to say.
Yeah, the tumor extends to the right atrium, you have to do it open. You could do a hybrid procedure. You do the bulk of your abdominal dissection with the robot, put a clip around the renal artery, isolate the vein and the vena cava, then put the patient on bypass, exsanguinate the patient, cool the brain, essentially kill the patient, and take the tumor out and then reconstruct it.